Any comments? Don't show your cards, huh?
I think it's finished. I think the last session, open this, is the just free open discussion, and you can ask any question. Okay. Papon, maybe you, Varut, you may need a paper and write down any comment so that we can improve for the next meeting.
A mic for Dr. Parvez, Sheikh. Microphone.
Okay. I go down. So this is let's discussion about this first, and then we go to the other. There are many things that I would like to ask from the floor.
Okay, so I think this is what Rojas has shown the chart. That is useful for charting the patient's details, but that can't be a classification like thing. That's only for charting, but it's a very good. So we can compare different types of surgery based on equivalent types of fistulas. So that's good for a study.
That the charting, not the classification.
Yeah, that's a classification.
But we can do the classification from REMI charting. We can.
Okay. Now this classification, what you have put up, I think is a good one, but we need to add maybe another couple of more types. So what
you should ask question. Yes.
Yeah. So
please.
What I would suggest is that we know that the high intersphincteric, the supralevators are always posterior. They never have anterior fistula which is going supralevator. At least I have never seen any anterior fistula which is going supralevator. They're all posterior. Because the whole aim of a classification is that then you can recommend for a low transsphincteric what should be the best treatment or what were the best surgery.
Yes.
Or the ideal, not the best surgery, but the surgical options at least. Mm-hmm. So when you say a posterior high transsphincteric fistula with a high intersphincteric type, that's a totally different type, where the treatment modalities also will be different. So that should be a separate type 6 posterior high transsphincteric with high intersphincteric extension. The number 4 and 5 combination.
Yes.
So that.
But that's the idea. I have the answer. We can report type 4, and then we can report type 4 mixed with type 5 at the same time. We can use two types at the same time. But that happened. But you are correct. This happen. Not so rare. It's quite common too. When you go have more experience, you will see this type in combination more often. So if we mix, I would like to have that type 4 and type 5 together and become the type 6, and that's clear. But we need other opinion. If we need type 4 and type 5 combination to be the type 6, maybe.
So when we say type 6, it means it's a very complex fistula. And the treatment for that will be totally different. Maybe the, the treatment options will be totally different.
Maybe from others' opinion too. Varut?
I think that the classification you propose is excellent. I think it's the majority, maybe 90% of the fistula we see is fell in these categories. But for about the rest, shall we classify type 6 as other? Because otherwise we not cover all the fistula we see.
Yeah. Which one? First, stop here.
For example, iatrogenic, for example.
Okay. I show you. I show you how. I showed you how. If you want that, maybe I can do something a little bit better. Thank you for comment on this aspect. This is what is iPad. I can report like this. It's a type 5 posterior high intersphincteric. Why we report like this? If we report like this, especially the extra, the treatment will focus on the extra and the primary tract in the same time, if we report like this. But if we report extra, we will focus on the extra and miss the primary tag, and that won't heal. This type is different from the type 4 and type 5 in combination, but this type is the iatrogenic. This classification is a natural pattern, but we cannot type 4 pass extra or type 4. In fact, it should call elevator. It should not call extra, but we can use the term extra in this case. Okay, that's what I mean.
My second question is, I think the key point for how to differentiate between low transsphincteric and high transsphincteric is still problematic because we have different opinion on this.
I have this answer. In the old day, it's difficult because nowadays we have the imaging study, and because we know more from the anatomy, so I will explain the high and low. Right? This is the accept knowledge. The high above 1/3 of the total sphincter. Okay, this is everywhere in the books, everywhere in the literature. But in fact, if I explain, the subcutaneous normally is only at least 5 mm in height. And the superficial, normally in the lateral, 1.5. In the anterior, the superficial may be 1 centimeter, in 1 centimeter. So 1/3 is more than enough. But we know that the fistula pass between muscle because if you look closely in the MRI or the ultrasound, you will know. So let's have a few slides and then more discussion. This is what I mean. Especially in the posterior, we see very clear it goes into the deep posterior space between the subcutaneous and between the superficial and the levator. We see that very clear. This is exaggerated because it shows lateral is not correct. It should be from the midline. Okay? So high tan mean above the superficial. Low tan mean in the subcutaneous. And this is that I show you. It's always, the high tan always occur anterior and posterior, never in the lateral. Extremely irregular in the lateral. I saw 1 or 2 cases in 1,000 of cases. And this is the high tan, only 2, anterior and posterior. And this is another one that occur with the posterior high tan. And that's all for the high transsphincteric. Yes, it's difficult, but if we use 1/3, it's okay too, because it all include. That's what I mean. We give this two things. Okay?
So what I feel is initially we should start defining what is high and low. I think that 30% we should remove. Above the superficial part is high,
No.
below is low.
At present, nowadays, everywhere we live in 1/3. We keep it,
No, but
we try to explain.
Because the whole classification is based on high, low, so we should first have the parameters, what is high and what is low. So if all of us agree that, and I absolutely agree that a high fistula is going above the superficial sphincter and the low is below, we should make that as a parameter, and then once we define what is high and low, then the classification will come.
Yes, I said that, but I just make a little comment at the end that maybe.
I think I agree with Parvez. If you don't define what is high and low, then you're always stuck in this point. So you have to define it first before you even talk about classification.
We define, yes.
Definition, very important.
We already said that, but we are aware that the other cannot understand, so we keep it. But we understand it's compatible. Both are compatible.
No, everything is compatible, but whether everything is helpful or not is another thing.
Okay, thank you. So we change it totally. Okay, next. An equation, and I try to explain.
And next question is, do you mean to use these anal sepsis classifications for cryptoglandular in origins only, or
Yes.
it's applicable for
Yes.
clone disease or non-cryptograndular?
Our
in origin?
intention is for cryptograndular, but but it can apply. It can apply to other rather, but we focus on the cryptograndular. But we can apply to other because it's the same.
Then that can be a separate type, say type 7. That includes Crohn's, tuberculosis, maybe malignancy arising from a tract, or other fistulas like iatrogenic, and all those can be, because those are not the natural cryptogranular patterns. Those are totally different. So that can be a different type.
So wait, Parvez, are you saying there's a type 6 which is iatrogenic?
I would still say the type 6 should be the high transsphincteric with the high intersphincteric extension,
In
because
combination.
the
Four plus
the
five.
combination of 4 and 5, because the management for that is very different. Then the management options are totally different. In fact, I see that maybe I do that combination 2 or 3 a week I do with supralevator extensions.
Yeah.
So people who are probably like you are doing high volume work will have more of those. Of course, it's not common and that's many times missed also. But if you have that as a type 6, so the moment you say type 6, it means a very complex fistula. That message goes on.
A little bit more complex.
So then 7 is for your iatrogenic, your Crohn's, your TBs and all that, is it? Okay.
Maybe that is a good recommend, but we will have a vote in all the experts that come to our table that we need the number 6 and number 7 or not. Yes, I agree with that, but we shall believe in other opinion from others author too.
I think whenever you come up with any sort of classification, for it to be meaningful and for it to actually be used, it has to be as simple as possible while still having an impact on either outcomes or prognosis or intervention.
Yes.
So while I agree that there are many permutations of fistulas, for it to be useful for us as a consensus group, for us to actually apply, for us to document and report outcomes, it's got to be simple. And I would suggest we stick to as few as possible.
At 5?
Yeah.
Okay.
Yeah.
So a good
But
idea.
there must be somewhere for you to annotate if there's some
But
variations.
even we have 5, we can record. Even we have 5, we can record. Yes.
Yeah, but not until 7, 8, 9, 10. I think it will lose its utility.
Yeah, you see, that's why my concern also is if you put one category for iatrogenic, you put one category for TB or Crohn's, most of our data right now is centered around cryptograndular. We don't have enough data points to cater for this group, you see. So we end up throwing a lot of things that we don't want, or we don't want to see, or we don't know how to classify into this group. I'm not sure how useful that will be. The danger also is to have this extra group, right, is that some people who don't have a full understanding of the classification will be very tempted to put it under the others. Whenever we don't understand something fully, instead of trying to fit it in, we'll just put it under others. So then we will grapple with a lot of inaccurate data, I think.
Then we have to clearly state that this is only for cryptograndular infection.
Yeah.
If you don't want to
I
include
think,
the
Professor
others,
Arun, when you first showed a slide, it was one of your early slides was a classification for the lift procedure,
Yeah.
right?
Yes.
Yeah.
In fact, I used something like this for a long time, but I never said it is the fistula, because I noticed that the outcome, anterior and posterior, and the low is different. The outcome is different when I record. It looks different. The outcome is different. That's why I record like that. I have low tan, I have anterior high tan and posterior high tan for a long time, since 10 years ago, because I know it's different. But I think there are many that we should clear at this time so that we understand the same thing. Any other question, just ask. And any problem, just ask. And then we will go to the next step.
So if we mention that it is only for cryptoglandular infection, then we don't need to mention the other types of fistula, as he says. But then that should be clear.
And
Actually, cryptoglandular does not exclude tuberculosis or even any
Yes.
other fungal infection, because cryptoglandular includes tuberculosis and also like fungal infection, because those are natural. So I mean, you can exclude Crohn's, but we always do, when we do anal fistula, normal anal fistula, cryptoglandular, you can get TB there. So it's not an exclusion. So if you say that those are exclusion, then you are actually going to exclude some cases from which are actually natural, because they can start with any sort of infection.
Okay. Next.
I agree that you stick this classification for cryptoglandular infections, because majority of the fistula we do is cryptoglandular infections, and keep it simple as much as you can. But the questions I ask maybe is make it more complex in terms of the straight or the curved linear, like semi-horseshoe, horseshoe, or horseshoe. Do you think is it necessary to add as a sub-classifications? Because sometimes I think horseshoe fistula may be a little bit more difficult to
Yes.
deal than the unilateral.
Correct. Because in the type 4, in fact, they are most common to the ischioanal. So we do not, if you are experiencing type 4 means ischioanal. But the type 4 and type 5 in combination, if they combine, there are many patterns that Lamy had shown you. There are 8 patterns in total of the posterior hiatal complex. There are 8 patterns. And this teaches you a lot. If you have the MRI and you understand this pattern, you can interpret very fast. This is this, easy. If you know all of this, and it's not very difficult if you pay attention to it. But for the general, we need a simple one. Just the type 4 mean ischioanal. Post-anal space ischioanal, the most common. And type 5 high intersphincteric issue, superior. That's all. What I want to. But if in combination, there are so many. Even anterior, if anterior hiatal is not that simple. There are many, the hole may be here, the internal may be the opposite side. There are something like this. It's ischioanal, but we can explain later. If we have include all the complex, maybe it's difficult. Maybe it's impossible to make a classification. Because if we put everything, cannot to make a simple.
Then it will become like Pankajkar's classification. It's so big and it's so confusing.
Yes.
Only thing we can add what he says, what Varut said was that whether we can have some like A or B indicate unilateral or bilateral, whether that can be just to each of the type, we can just add. Also whether abscess is present, not present, whether that should be included in the classification. Mm-hmm. Track with abscess or without abscess,
In fact, we think about this, everything about that you all comment, and then we come out with the other system, the recording system, and I call it anal fistula map, I call it. But this system is not the classification. It's just the adjunct for the classification. It's just to record the data. But very easy. This system, if you want to know, I can show you. It's easy. And if possible, I would like all of you, if you still have strong enough, if you have energy left, maybe I give you some tests, if you want. So maybe we can give the papers, so that at least they can bring back home for what is the anal fistula map. Okay.
Arun, the other.
Yes. Yes.
Yeah.
Thank you, Arun, for giving me the clear answer. There was 2 questions when I finished my training. One was hernia. I couldn't accept the concept of a hernia operation when I finished the training, and it has changed. Right now, I can accept the operation that done these days. For the Anal fistula, I didn't have much experience, but whenever I do the operation, I was confused. What in the book is quite different from what I'm seeing right now. Now you give us a clear answer, so I hope we can discuss it later in the Asian Pacific Federation meeting in Malaysia next time. So please distribute this concept to all the societies. Before they come, they can see and discuss.
Yes, can.
Yeah, it's very good. Thank you so much.
So you have the paper? Hey, somewhere here they do not receive the paper. Hey, Suoti, you already have no. It look compact? In fact, it is not.
Arun, another important input we need to get is from the radiologists themselves. The radiologists. I have not had success talking to our radiologists because MRI is not often covered by insurance. You obviously, in the last 2 weeks, was able to convince one of our radiologists to report it that way. Can you give us more input on this? Because this report is going to be also done by radiologists, right? Secondly, in the reality is endoanal ultrasound is not going to be done widely. It's going to be limited to colorectal surgeons only. So MRI is going to be crucial. The second point is, in those situations where there's no MRI and we rely only on surgeons, and if the surgeon is not as experienced, how are we going to deal with that scenario? Are we going to limit this first to specific surgeons who understand the anatomy? Or are we going to allow every surgeon who does fistula to report it this way, in which case it might be problematic?
Okay. This is not the classification. This is the record data. But we can draw the classification, any classification from this record. So let's say internal opening at 3 o'clock. Internal opening at 3 o'clock. It's just track, intersphincteric fistula tract, and go out at external opening is perianal area. External opening at 3 o'clock, 1.5 centimeter, like this. But we already developed a shorter way, is a proforma. This is a table. I give the table to everyone. And in this table, you can see internal opening at 3 o'clock. Just set 3 here. Intersphincteric fistula is a track. Just track here. Level is past intersphincteric here. It come out with the track at external opening perianal space. Perianal space here is a track at 3 o'clock and 1.5. So if you have this proforma, you should just tick, 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 and this is the data record. This one is IT intersphincteric, pass between internal and external. You already have the paper? Do you have the paper? Or already explained in there?
What about laterality or the clock? Do we still use that?
No, because of the clock phrase, you will know where it is. You will know. No, let's have a look at many examples. Let's say, if we record like this, internal opening at 2 o'clock, external opening, internal opening at 2 o'clock, intersphincteric plane, intersphincteric with a track, rotan, because it's rotan. And then it go to the perianal with a track, and external opening at 2 o'clock, and distance 3 centimeters. Even the MRI or the ultrasound, you can record, and you have everything in here, have everything. And you can draw any classification from here. This is just I call it a fistula map. The develop, at first we plan to have a good communication with the radiologist and find out that we can draw the classification from here. Let's say, if you have two things, one come out here and one go out there, so we have to record in two tables. We record the first one, internal opening at 6 o'clock. It go intersphincteric space with abscess. We can see the abscess only during operation. And it go out, not to the post-anal space, but it go out at 5 o'clock, past the superficial. We know it cuts here, so it's high tan here. And it go to ischioanal with cavity, and it end at by tract, by end, BE, by end. So it's not open now, the abscess. The other one is go up, so we second track, 6 o'clock. It's an abscess, intersphincteric abscess. Do not pass the muscle, but it goes superior is a by tract. At the distance from here to here is 4 centimeters. Distance from here to here is 6 centimeters. So if we record like this, we can draw any classification from the record. We can draw. And because already have the table, it's easy for everyone. Even in the operative note, you just circle 3 point, 4 point. Operative note is easy now. Again, if you see this one, the internal opening here at 12 in the anterior is passed above the superficial egg, so it's high tan. But when it come here, it become the abscess. So the abscess is here, and it's in bright tract because now it was not drained. So, and it's 8 centimeters from here. So this is the record. It's the same, but this is newly developed to communicate with the radiologist. I give this one to the radiologist and ask them to lift out every case like this. Even we have three combination, we can record. We can record everything. Even past the elevator, we can record, but a little bit we have time. If we, any case, if we have inferior and superior at the same time, it means that it's past the translevator. That's all. We just understand something. A little bit more difficult, but if you practice, it becomes easy. So because you want to see this, I already show you, then I will ask you to have some example for me. You already have that. So look at the second page. Try to record this. I will explain to you first and then you record. The anterior 12 o'clock is go above the superficial and it go out just here. So 12 pass above this at the track and come out external opening at 12, okay, and it's only 2 centimeters. So it's in the first exercise, please mark it. I just want you to do a correct remark or not. Huh? No pen? He had no pen. Give me for him. This is posterior, you see. This is the coccyx. This is anterior. Anterior is 12. Anterior is 12. So, this is the external opening. External opening at 12, and this is 2 cm apart. Not very difficult. Because this is simple exercise, then go to the more complex exercise. The more complex, you have 2 tables. So go to the second exercise, you have 2 tables. Okay? This is the next one. From here, the first one It go from here to the abscess here, come out, tan sphincteric here, high tan here, to external opening here, at this one maybe 3 or 4 o'clock, or 5 o'clock, and it's 3 centimeters. And this one, the second one, go here to deep post-anal space, and the abscess here, come out here, and external opening is here, is something like this. This is the post-anal space side. Triangle is a post-anal space. So there are 2. So you record 1 first and then second. And this is maybe 6, 7, 8 o'clock in this area. So just go to the second exercise. Huh? No, this is external opening, just external opening. This is external opening, this is external opening, because at the skin, external opening. Yes, abscess is here, because I know this side is the abscess, this side is the abscess. You see, and when you do all of this, finally we will test again. We will bring this to someone and ask them from your record to draw the picture. Just give them the record and ask them to draw the picture. Is that correct or not? Okay, I think you finished 2 exercises now. I want that 2 exercise to evaluate. No fail, because we just to look at our understanding is correct or not, that's all. Okay, I think I already finished. Already finished? If finished, someone please correct the paper.
So before you hand the answer sheet back to the staff, just complete the heading.
Oh, the first one, keep it. The one you can keep it.
Yeah, but the heading of the mapping, like the age, the countries, your experience, your professionalism, just complete it so you
Yes,
know.
please, complete a little bit if you can. If you can, please do that. Because we did some study. Maybe come out with a poster session in Malaysia. Okay? So April, make it a good one, because we will bring this to poster session in Malaysia. Oh, go back to the first one, sorry. The first one is simple. 12, high tan, and 12. 2 centimeters external opening. The first one is easy. The second one is 2 track.
So will that space be perineal or perianal?
This one is come to perineal space here. It's past the perineal space here. And also past the perianal too. Pass both. They pass both. Because this is a perineal space, PRN, and this PRA, they pass like this. It's difficult? Easy. Oh, very good. Thank you. Okay. I still have time, but I think many feel, I look at them, they look fatigued. So maybe if we go further. In fact, with this record, I would like to ask the Philippines, Malaysia, or Singapore, even Thailand, even Siriluck, to go back and put 6-month retrospective in the data, and we can present all of this in Malaysia. It's okay? In your hospital, that can be done. It's okay. Okay, he asked one question. If we see that, is this surgical finding enough for identify the type of fistula? I think a simple one, operative finding is enough. For a deeper one, you just record it, and then you just record if you have the MRI or ultrasound together. Just that it's compatible or not, just confirm by both. If you have MRI ultrasound, please repeat in the same. Please know that are there any different by the ultrasound and the MRI. If you have record and if you have the imaging study, please note it. We will talk again. We will talk again. Okay? Okay. Please, give the microphone to him.
Well, I see this as an opportunity for us to do a multi-center validation study. If perhaps we can request the study group, okay, to develop a validation protocol, identify the centers or countries, societies that will commit to perform a validation study and try to validate this classification and recording system. Of course, it may have to be limited to the centers that have anal ultrasound and MRI facilities available as well. But I would suggest that, because I really see this as an opportunity for us, especially in the ASEAN, and now we have representatives from Korea and Japan as well, to see, use this, accept this initially, but validate it in the population of patients that we have. But we have to have a standard protocol. We have to have a very short training session as what we're doing now, so that the principal investigators who will commit to the validation study will be, properly trained.
Yes.
That's how I see we can all move forward scientifically on this.
Yes.
And really decide whether we will adopt it or there will require some modifications still.
Yes. Yes.
Because as you say, this is a work in progress, Rami, Arun.
Yes.
I think that's the way we can move forward.
Yes, that's what I want. That I want to hear from you.
But there has to be a standard validation protocol study that will
Yes. Look at this. That's what I want to hear from you. In fact, I already think many things. So, if you want to move, one, I can report my personal cases and data. Yes, I already have. And then we can have retrospective is good enough for 6 months or a year. Maybe 6 months is enough. Or a year, maybe a year, because you do not have too many cases. Maybe from the Philippines, from the Malaysia, and from Singapore and Thailand. Thailand means Siriluck and Jirawat, different in a year. And then we can have 5. In 5, at least we have 200. At least we have 200. And then we will show this in Malaysia. No, maybe you can decide someone to contact me. Yeah, maybe she can take it.
Arun, just some questions on methodology. Retrospective, easy for MRI. I'm not sure about ultrasound because I don't know if we record it.
It's just operative record.
Operative records, I'm not sure if everyone has done as detailed operative records.
I think
For operative records, it may have to be prospective. I don't know.
In the major hospital, they always have a good record.
Record is okay, except I never measure length of the fistula. We don't really measure the length of the fistula.
Yeah,
as
right.
such.
I
So
don't-
that thing is definitely going to be missing.
I know. Yeah. A lot of data is going to be missing if it's retro.
Length is I never measure.
I don't.
It means that we need another 1 year to collect the data.
No. What I'm saying is that internal opening, external opening, that sort of thing we always record, right? But length of fistula, I never record length of fistula.
Why not make it prospective at the
It's
very
not
start?
length, I think. So, Francis, it's the distance from the anal verge, right?
No. Finally, I changed because it's difficult to measure. So I measure the distance from internal opening to external opening.
Yeah, I mean, I don't think you measure either. right?
No, we don't.
That's MRI and operative.
I think
from-
we are totally incorrect. First, maybe if we need more case immediately, or a little bit maybe before
now to
your
April
meeting.
you can do lah.
Maybe
Yeah, prospective.
I
From
think
now to April.
maybe
what I would,
maybe retrospective is enough for 1 year, and you too. India, Thailand for 2 stations, Singapore, Malaysia, the Philippines. Now we have 6. 6 at least 300 easy. Retrospective first, and then if it's good enough, the next step is a 6 month in future.
I think there is some useful information to be had from a retrospective project, because this is like synoptic reporting, isn't it? One of the goals here is to ensure that we report more adequately. So if you do a retrospective, you will actually then have evidence of how much we are leaving out from our reports, the missing data. And I think that's very useful to push for this to become part of our practice.
First, I will post this, and I will know you where I post. Even the format, everything I will post in the internet. Unless Parvez know, and then where can we
So
go
we
further?
do a retrospective of 1 year. Is
No,
it?
1 year retrospective.
Retrospective, right?
Only a
And
few
then
of
we
us.
will report even all the missing data, whatever is
And
missing.
at that time, we can analyze very fast.
Sure.
Because very fast, and then we can present at
Yeah.
any time.
But hold on, I'm still stuck with the internal opening to external opening distance. How are you going to measure that again? Sorry, Prof.
No. The distance from the internal to external opening, don't worry. If we can make it, just make it. If we do not have the record, just omit it.
But even the length, I mean, you are trying to allude to the length of the inner fistula, but for certain
Normally-
tracks where they are so curvaceous,
Normally, we
have
have the length from the anal verge. Yes, I understand.
Yeah.
But it's difficult to measure because everyone have different idea. So from internal to external opening is okay. But if you cannot have this number by retrospective, it's okay. Do you want to involve? Do you want to get involved? China? Nanjing?
microphone for.
I think it's very useful for the record, but I still have some questions about that. That's retrospectively, because for the classification, what's our aim? Is it for the success rate for the operation, or only for the research?
No, from that one, we can draw from this performer, from the record, we can draw out the classification easily. The next step, if we analyze, maybe just very simple one, I analyze today, maybe patient in a post-session in Malaysia, and if we finish our retrospective fund year, maybe we can send to Dr. Chun, Professor Chun, for publish in your journal.
I think-
Easy.
Yeah. I think what
It's not a good one. I think retrospective is not a good one, but it's a small step forward.
I think what Prof. Arun is trying to say is that this recording system should capture enough data to see whether from whichever country you're coming from, whether your group of fistula patients can fit into the proposed classification that he has proposed. That is the 5 categories or
I will send to you.
6 or whatever, 7, So if through this data collection, you find that it cannot fit, Then maybe at the end of the study, you may have to propose a
Anything new.
modification.
Yes, yes, correct.
So it's just a very standardized, as complete as possible data collection.
Because
pro forma.
retrospective cannot be complete.
Yeah.
I understand the limitation, but the internal opening and the direction will be there. External opening will be there, no problem. But how far, maybe not. But I think maybe now we have many friends, Rami, Appeal, Varut, Parvez, of course, you are a big guy. And you want? Sahu, and maybe Shao, retrospective, easy. Now we have many. So I will send the performer to all of you. And then you can, maybe next time in Malaysia, we can show. Even we can finish before, just send me and we can
What
correct.
deadline?
Huh?
What is the deadline for submission?
We think, I tell you. We will think about it and we tell you. Many things we can make a decision.
I want to just say one more thing. In your classification, or rather in your pro forma, I suggest you should add histology, you know, for now anyway.
Yes, in the description, we already said that is for only for crypto can do.
No, I know, but you should add the histology there just to see, because if you do all these things, in the end you'll find your histology is not there. It's also not a validated.
We will send you the paper too.
Huh?
Something that I have written, I will send you.
Oh, no, but what I'm saying is that for this, you should add the histology to say this is, you know. Yeah, all have histology. Just put the histology of your fistula you're doing.
Histology, what do you mean?
Histology.
Histology.
Histology. Oh.
You should have a.
Retrospective, impossible.
No, we should all have what?
No. Retrospective, impossible, because we do not send histology in many cases.
We always send.
No.
I always send all my.
We send
Yeah, I always
only
send
maybe
also.
10%.
Yeah. The reason is because some of them can be turned out to be fungus, TB, and all sorts of
Yes, the tuberculosis. One of our Indian friends, he said that he start PCR, tissue biopsy and culture in 50 cases, and he said no, so he stopped. When we look at the Garg's paper from India, he said that he sent the PCR and the culture and the histology and found out 10 or 12%, and he said that PCR is the most reliable. But when compare the PCR and the culture, is the most reliable compared to. But the tissue is not reliable, he said.
Yeah, but it doesn't matter. But at least we put it there to say that.
So
it is or
it
it's not.
means that we have to send PCR in every case for tuberculosis.
Yeah,
we have to send the
just
PCR in every case.
No, just biopsy lah. I think. Yeah, every case I do biopsy also.
No.
If they recur, I send every case.
Yes, but okay, we will think about this and we will focus about this in the next prospective data. We will put it, but in the retrospective, impossible. Impossible. Okay.
Can I, in addition, do you want to have the surgical procedure?
Oh, at first maybe we do not. But we will tell you again. We go back and think, and we will send more data to you.
Oh, different. Everybody do different.
Because our main purpose is
to-
just come out with the
Yeah, it's not to see results. It's to see
with the classification.
the types.
That's what we want. But in fact, we should have the result of the operation, because to strengthen the classification. If the classification can predict the outcome of each procedure, that is the best. But maybe we plan to do that. Maybe. Yes, prospective. We should plan to do that. But it's a small step. I just want a small step ahead. Okay. There are many questions. In fact, there are many other questions. There are many questions like this, many questions. But I will stop here because we feel headache, fatigue. So thank you very much. Thank you, and thank you.
Thank you to all professor. That was such a gripping and intense session, and this is my honor to be here and listen to like a small step but powerful one for colorectal societies. So, ladies and gentlemen, please give a big round of applause to all of our speakers again. And on the behalf of the organizers, I'm very grateful that our honored speakers here have taken time out of their busy schedule to speak at our symposium.
And as we reach the end of our fruitful two-day conference, heartfelt thanks go to the organizing committee and the sponsors, of course. Medtronic, Johnson & Johnson, Olympus, and Bebron. Without them, the conference would not have been possible. And also, we would like to thank all of you, the audience and the speakers that have took your time to be here with us. Without you, the conference will not be complete.
Before we reach the end of the conference, may I invite all the speakers on the stage to take a photo together. Please.